Okay. So, hello everyone. I hope everyone is okay. We are going to start. I wanted to start with introductions. So, I'm Dr. Frieder. I'm a perinatal psychiatrist. I'm the medical director of Present for Mom. That is a consultation line that in Montana, that providers can call us if they have any questions about how to treat perinatal patients. So I encourage everyone to call us. We are here to help. So why don't we start? Who wants to start with introducing themselves?
I can go. My name is Megan Fallon. I'm a therapist in Billings. I'm an LCSW. I work primarily with moms and especially a lot of young moms. It seems like older adolescents. I'm a certified perinatal mental health specialist. I have been in private practice for about 5 years now. Let's see what else. I am kind of a PMAD survivor myself, and really got into this stuff in the last couple of years after my daughter was born, and I just saw the lack of support and resources. So welcome.
Thank you. Let's see. Amber, do you want to introduce yourself?
Amber Rogers with Mountain Pacific Quality Health. And just another reminder, please put your cameras on. It helps us see your interesting faces and helps our presentation.
Yeah, I was going to say that in a little bit. Mary?
Hi, Mary Argonis, Mountain Pacific. I'm at the Hawaii office and your IT support. Thanks.
Thank you. Brandy? Do you want to introduce yourself?
Hi, I'm Brandy Colvin. I'm a family nurse practitioner in Bozeman, Montana, and I work for Providence Mental Health.
Great to have you. Stephanie?
Hello, everyone. My name is Stephanie Morton. I'm the program manager for Healthy Mothers, Healthy Babies. Nice to see you all on here.
Hi. I'm going how my camera is. So, Sarah Beth? We can't hear you.
Oh,
I think you're muted.
can you hear me now?
Okay. Yes.
Okay. Hi, everyone. I'm back in the office, so the setup's a little bit different, but I work in the Montana Medicaid office, and that's where the HRSA grant is housed, and this HRSA grant helps fund the Prison for Moms line, so I'm really excited to be here.
Thank you. Cassie?
Hi, I'm Cassie Bronson. I'm a nurse practitioner graduate student. I'm in Missoula, Montana, and I'm doing my dissertation work around substance use in pregnancy and really interested in perinatal mood disorders as well. Thank you.
Great. Ray?
Hey everybody, Bree McLaurin from Healthy Mothers, Healthy Babies, part of the ECHO team with community-based referrals.
Right. Okay. Anyone else wants to introduce themselves? Okay. So today we are going to talk about psychiatric emergencies. I'm going to share my screen. Let's see. I don't know, how do I show my screen here? Okay, can you see my screen?
Yes.
Perfect. So it's our session 6. It's impressive. We are already in session 6. So today we are going to talk about perinatal emergencies, mental health emergencies. So first of all, any announcement, anyone wants to announce anything or has anything to say, please, you can say it now. Anything you want to share? Okay. So before we start talking, I have a poll. Mary, can you put the poll? Have you had cases of active suicidal ideation or suicidal attempts in your perinatal patients? Are people answering? Or...
We have 58% of the people that have answered right now. Oh, 71%. No, let me say that again. Yeah, 58% people participated. So let's go ahead and end that.
Yeah.
You can see that 71% of people said yes, they have experienced this.
Yes, yes. Okay, perfect. And now can we see the next poll? Have you had patients with postpartum psychosis?
Okay, so I think that's probably, we have 61%. Some of the folks attending aren't in active clinical practice, so they probably aren't answering the question.
Okay, so mostly not. Okay.
But if you want to share the results, if it's not on your
Yeah, so 38% said yes and 63% said no. They didn't have patients with postpartum psychosis. And can we see the next poll? Have you sent any perinatal patient to the emergency room?
Okay, looks like we have 53% participating.
Okay. So 71% said no and 29% said yes. Okay. So it gives us an idea of people's experience with emergencies. So we are going to talk today about psychiatric emergencies in the perinatal population. So we are going to start talking about suicide. And it's very important to think about it because suicide is the leading cause of maternal death in the first year postpartum, and with 1 in 7 deaths in the first year postpartum. And it's very interesting because women with a history of psychiatric disorder, they are at the highest risk of psychiatric admissions in the first year postpartum. And from people that commit suicide, few have contact with a mental health provider, like 19%. More have contact with a primary care provider within a month of their attempt. But we see, and I think it's more frequent than this, but in the literature, it says that 5 to 14% of women with postpartum depression have thoughts of self-harm. So the suicide risk really of dying of suicide during the perinatal period is estimated to be 1.6 to 4.5 per 100,000 live births in the United States. with this information, it accounts really for the first 6 months postpartum, and we don't have it doesn't really account for after the first 6 months, and it's really underreported in death certificates. So it's really most likely that the suicide risk is higher. And of women seeking care in obstetrical care, 2.7% endorse thoughts of ending their lives. In women that go to mental health care, it's higher, as you see, 5 to 14%, as we said before. So risk factors for suicide, very important. A history of psychiatric illness, very important. Bipolar disorder, they have higher risk of suicide and more likely to die by suicide during pregnancy than women with unipolar depression. So a history in the past, a lot with bipolar disorder, history of suicidal attempt. Women that stop their medication abruptly when they found out that they are pregnant, that puts them at a higher risk. And that can be for several reasons. It can be because the illness comes back. It can also be because the withdrawal that they experience can be very uncomfortable, and that with the disease coming back can be a lot to tolerate. Sleep disturbances during the postpartum period, intimate partner violence, having a stillbirth, having anhedonia, and like lack of self-care, lack of interest in bonding with the infant, the difficulties they attending to their hygiene or neglecting medical needs. So these are the risk factors for suicide that we need to keep in mind and pay attention when women come, and so ask about them. So we need an early screening, assessment, monitoring, and intervention for all the patients, regardless of how they look in their appearance and how they look emotionally. So they can be cheerful, they can seem happy. We still need to screen and ask, because they can hide it, you know, they might not be showing how they really feel. So one way of screening is with the EPDS, the Edinburgh Postnatal Depression Scale. We spoke about it. It's a scale that we use for depression in pregnancy and in the postpartum. And with that, we get information about if the woman might be depressed, but also question 10 asks about suicide, thoughts of suicide. And so if that question is yes in any kind of way, we need to ask more questions about it. Also, we can use the PHQ-9, and that's totally valid. Then if somebody seems to be depressed, we always need to find out if they have bipolar disorder. So one screening that is good is the MDQ. It's a good screening measure that you can use. It's very fast, 5 minutes. The woman can answer it herself, and you will get an idea if she might have bipolar disorder. It's better for bipolar 1 than bipolar 2 or bipolar NOS, but it's still good to pick up some women that might have bipolar disorder. That will help us figure out who is more at risk, and also for management. So it's good to screen at every contact during the first year postpartum and also during pregnancy. And as I said, with the EPDS or the PHQ-9, and you can add the MDQ to screen for bipolar disorder. And if they answer yes to the suicide question in the EPDS or the item 9 of the PHQ-9, you have to look more into that and ask more questions. You can also ask directly to the patient if they have any thoughts of suicide or self-harm, and really try to figure out what is the severity of the thoughts, the frequency, and if there is intent. Because a lot of women will tell you, I wish I would be dead, you know? But what you really need to see is there a plan? Are they going to act on it? You know, do they have any protective factors? So we need to look at the whole situation, not just at the thoughts, but like really we need to assess the situation to see if our assessment says that they might act on it or not. If we think that the woman might act on the thoughts, and even if we are unsure, you know, if we need somebody else to lay eyes on the woman, we can ask for an emergent psychiatric evaluation for the patient. So when somebody has suicidal ideation, it's very important to contact a collateral, you know, somebody that is important in the woman's life, a significant other or preferred family member that will help us understand what's the situation, you know, so help us see if the woman has been talking about it, maybe wrote a letter, maybe has been looking into means at home, and if there are any means at home, ask the family member to remove those means. If you are thinking that the woman can be at home instead of sending them to the hospital. If you are thinking that the woman is not going to act on her thoughts and you want to send her to the house, it's very important to establish that person that will help you in terms of paying attention to her, you know, and being aware of what are the risky behaviors, and will be able to call if needed in the case that things get out of hand. I'm always a little bit concerned about this. And in my experience, when I'm concerned about somebody to this point that I need to ask the family member to be looking over them, I usually send them to the emergency room for an evaluation and for an admission, because I don't want to put in the family member that burden. And also that family member can fall asleep, can go to the bathroom. Like, you can't ask that person to be 24 hours watching the patient, you know? So if the patient has suicidal ideation, but it's not to the point that they are going to act on it, you can start with pharmacotherapy, and you make a plan until the next time that you will see them. It's very important to ask about protective factors, because that will help you identify who is not going to act on them. How, like, some women will tell you, my kids are my protective factor, my partner. So that will make you think, okay, this person has reasons to live and will not act on it. And if you think that a patient needs to go to the emergency room, you send them. So in terms of postpartum psychosis is an emergency. It's a true emergency. There is increased risk of suicide and infanticide. And it is associated with negative effects on the child, like delayed social, emotional, cognitive development of the child. It usually happens 1 to 2 cases per 1,000 births, but if it is associated to bipolar disorder, it can be more. And usually it's an abrupt onset. It starts within 2 weeks postpartum in most cases. And what you usually see is, like what I tell people, it looks like a delirium. Like, women are irritable, their mood is up and down, they don't sleep, they might be manic, depressed, have mixed episodes, they might have delusions, sometimes they have obsessions, they might feel disoriented, confused, and a lot of them have thoughts of suicide and homicide. And the delusions many times are religious or delusions about the baby. So it's very, very scary and very concerning. So because it has an abrupt onset and it starts in the postpartum, and because 50% have no prior psychiatric history and no prior symptoms, you need to rule out that there are any medical causes or any substance abuse involved. So when you see somebody like this, you will send them to the emergency room, and they will need to have blood work, head CT, and they will need to be evaluated very thoroughly to make sure there's nothing else going on before assuming that it's just postpartum psychosis. So risk factors: first pregnancy, advanced maternal age, when there is a mood disorder during this pregnancy, very, very important, history of bipolar disorder and history of postpartum psychosis. So if a woman has a history of postpartum psychosis, that puts her at an increased risk of having another episode. And if the woman has a history of bipolar disorder. Also, if a woman has a family history of bipolar disorder, when they have a first degree relative with postpartum, I'm sorry, this is wrong. If a woman with a first degree relative with postpartum psychosis and they have bipolar disorder, they have a 70% risk of onset in their postpartum. But most cases of postpartum psychosis present in those people without a history. So that's very, very important to remember. So women that are at risk of postpartum psychosis, you will be very careful. Like what I do is my patients with bipolar disorder, or if they have a history of postpartum psychosis, I have a meeting with them and their family member, and I discuss what are the signs of postpartum psychosis. I discuss sleep, so important to sleep, that when the baby is born, they will need to sleep. Somebody will need to help with the baby because we need to avoid the postpartum psychotic episode. So really you discuss what are the signs of postpartum psychosis, or somebody can call you as soon as something looks not okay. And you will schedule a follow-up with the obstetrician, nurse, or psychiatrist within the first 2 weeks postpartum. So what are the differential diagnoses? So anything that can be medical, like an infection, postpartum hemorrhage, thyroiditis, autoimmune disease, or, as we said, bipolar disorder is associated with postpartum psychosis, schizoaffective disorder. It can be a brief psychotic disorder or schizophrenia. So we usually see it a lot in people with bipolar disorder and schizoaffective or schizophrenia. And what do we see in bipolar disorder? Usually bipolar disorder is people that have 1 week of persistently elevated or irritable mood with more than 3 of symptoms of these symptoms and marked impairment in functioning. So the symptoms can be distractibility, indiscretion, grandiosity, flight of ideas, increase in goal-directed activity, no need for sleep, pressure speech. So you have to look for bipolar disorder. So more than 50% risk of recurrent postpartum psychosis in women with bipolar disorder or schizoaffective disorder. So that's very important. So if they have bipolar disorder or schizoaffective disorder, and they had a postpartum psychosis, they had a risk of recurrence more than 50. And as I said, if they have bipolar disorder and a family history of postpartum disorder, it affects 74% of these women. And it affects 30% of women with only bipolar disorder and no family history of postpartum psychosis and no history of themselves of postpartum psychosis. So you will send them to the emergency room to have a physical examination. They will do a CAT scan to check their head. There's no mass, there's nothing going on. A workup, a blood workup, a complete blood count, metabolic panel, thyroid function, ammonia. Sometimes it may require calling neurology and having a lumbar puncture or EEG if you're thinking about an autoimmune disease, and you are going to rule out substance abuse. So you are going to do a urine toxicology screen. So the management, the drug of choice to treat postpartum psychosis is lithium. And what you do is you start the lithium as soon as the baby is born as a prophylactic in women that have a history of postpartum psychosis. This is in women that have no symptoms but have a history, you start the lithium. If a woman has some symptoms and you suspect it, as I said, you send them for an evaluation or you call psychiatry or you do the evaluation yourself. And it's very important to hospitalize these women because it's very, very risky. These women can kill themselves and kill their babies. So you are going to do the complete workup for treatable diseases. And so if the woman has symptoms, you start the lithium, and usually the way you do it, you also add an antipsychotic and a benzodiazepine to reduce the symptoms, the psychotic symptoms. But the lithium is the main medication, and you have to continue it for 6 to 9 months. And you need to avoid using antidepressants in these patients without a mood stabilizer because it can make the mania worse. So the treatment is, if the patient is acute, you do lithium with an antipsychotic and benzodiazepine. Once the patient is okay, you gradually stop the benzodiazepine and the antipsychotic, but the patient should remain on lithium for at least 9 months postpartum, 9 months of treatment. And if the patient is stable after 9 months of treatment, you can gradually taper off the lithium. So they did studies and they saw that women that took the lithium over the 9 month period had a 10% relapse, and women that discontinued the lithium over the 9 month period had a higher chance of relapse. So I just wanted to mention ECT because in some women.
Dr. Frieder, can I interrupt you for just a second? This is Amber. Just before we move on to the next, we did have a question in the chat box about the diagnosis. Do they always do a head imaging as part of the rule out for postpartum psychosis?
So if somebody has no psychiatric history from before, if they come and they have no history of bipolar disorder, no history of nothing, like it's the first psychiatric episode in their life, it's good practice to do a head imaging. Yes.
Okay, thank you. Any other follow-up questions on that from the group before we move on to the treatment?
I had asked that question just because I could see some of our ED docs here not being just like really going to the psych piece first and not doing a full workup and a rule out. So I think I would just want to make sure I can help advocate for my patient. And when I do I often, if I do a referral down to the emergency room, I'll often, talk with the team down there and give them my concerns. And so that's something I'd want to make sure I suggest is if there's any way they could do some really good medical rule out. But I could see them just like going for the psychosis disorder or the psychosis diagnosis right away.
Yeah, it's very important because if somebody has no history of anything and suddenly they become psychotic, even if it's not postpartum psychosis, you have to do some medical workup to rule out any medical issues,
Sure.
So this is the same, and there are other reasons in the postpartum that women can become psychotic that is not just the psychiatric issue. So it's important.
Thank you.
Sure. So I wanted to mention ECT because it's a treatment of choice sometimes when patients are very, very sick, when they have severe depression, mania, psychosis, when they are at high risk of suicide, violence, catatonia, or when they are not eating, when they are dehydrated and they can't really take care of themselves, sometimes you need it. And they published cases for many years, and the risk of adverse events for the mother and the fetus are really low. So it's a good treatment. It's a safe treatment overall. Like you won't want to do it as first line because women need to be under anesthesia for it. So you will always want to try medication first. But if a woman is at the position that she can't take medication or she is so agitated that they can't calm her with medication, you might need to use ECT. And even in pregnancy, you can use it and it's safe. I had a patient that was with postpartum psychosis and they used ECT, and it really helped her. Then she got pregnant again, and the question was if were going to continue with the maintenance ECT or not. But the problem is that after the second trimester, when you do the anesthesia, you need to intubate them. And so she was scared of the intubation, so she didn't really want to do it, and she was right, you know. So she decided not to do it, and she was doing better. It was just maintenance. So, but it's a treatment that you can use if you need. And then I wanted to talk about agitation, because this can happen too. Women can come and they can be combative, aggressive, restless, with extreme irritability. The important thing is to figure out what's the cause, what's going on, why they are so agitated. And potential reasons could be a psychiatric disorder like postpartum psychosis, bipolar disorder, schizophrenia, a medication withdrawal. You know, that's what I was talking at the beginning, like a risk of suicide. Like if somebody abruptly stopped their medication because they found out they are pregnant, they can become agitated. Also, if they are intoxicated with drugs, or if they are withdrawing because also they found out they are pregnant and they don't want to use drugs anymore, that can also cause agitation. Or if they have medical causes and they are delirious. And this is something very important to keep in mind: the abrupt discontinuation of psychotropic medications and drug of abuse and alcohol is a common occurrence during pregnancy due to concerns about fetal risk. And it's very important to keep an eye on them, you know, because they can become very agitated. It's very uncomfortable. So what do you do with somebody that is combative, you know? So first you try to de-escalate, you know, verbally by speaking to them in a calm and low voice. You keep distance, but you try to look at them at the same level, not from above, you know, but really, really try to talk to them in a very calm and low voice, but keeping yourself safe. You don't want to be too close. And if you have a feeling that this is not going to go well, you leave the room and you might go for medication, you know? And the medications we use really have to do with what's the cause of the agitation. But if it is a psychiatric cause for agitation, one of the things we do is we use antipsychotics as first line. The haloperidol we use a lot, or perfenazine. We sometimes use second generation antipsychotics like olanzapine. And sometimes you need some benzodiazepines, you know, like lorazepam. And you can use it if the patient is willing to take it medication orally, you use it orally. If the patient doesn't, you need to use it intramuscular. You know, the question about safety, it's less important here because two reasons. One, if the patient is agitated and combative, she can put herself at risk and others. So that's more important in the moment. But also because one time that you use these medications will not really affect the fetus. So it's very important to keep the woman safe. That's the most important thing. So any questions about this? And here you have the referral line for prisons.
I have a question, but in the chat a little bit earlier, there was a question about if a woman can refuse to allow the doctor to talk to family members, or can refuse providers. And my response, and I'd like to hear from you, Dr. Frieder, you know, my response is that technically, yes, like patients and clients can refuse to allow, you know, their providers to talk to outside sources. In my practice, I make everyone have an emergency contact on file, and then I get a release of information for that emergency contact. And it's part of my informed consent that, you know, if an emergency is to happen, this is who I'm going to contact, and I have your permission right now. but oftentimes I've also found in those situations, most of the time the clients are really open and engaged to treatment and they want to feel better and they have no problem having a family member or having us have contact with somebody else.
Yeah, it's always better to have somebody on file, to contact. But if it's an emergency, depending what type of emergency, and what you are concerned about with, let's say you don't have any contact on file, but the patient is telling you she might harm somebody, you have to tell that person, even if you don't have any consent to talk,
Right.
and, or you send the patient to the emergency room. You make sure that patient is hospitalized. And so if you are in the situation that you can't talk to the family member because you don't have a consent and you think that, like for me, if it's an emergency, it's an emergency, like you can talk to other doctors in case of emergency, and sometimes you can talk to family members if it's needed. Like if you're going to save the
Right.
woman, from hurting themselves.
Yes.
But a safe way is to send them to the emergency room.
Mm-hmm.
I have a question.
Yeah.
For the prescription of lithium,
Yes.
is that something that OBs and NPs would prescribe just to get started and then have somebody in the psychiatric field manage that? Or is that because I know that there can be a delay in you identify somebody who needs maybe lithium, but then getting them to like a psychiatric provider can be quite the delay. So what are your thoughts on that?
Yeah, that's a great point, because it happened to me not so long ago that I had a consultation of a patient that needed lithium because she had bipolar disorder and she was psychotic in the postpartum. And I suggested lithium, but the midwife didn't feel comfortable managing lithium. And I totally understand it, it's a difficult medication to manage. So in my experience, it really depends on the OB and the NP if they feel comfortable managing lithium or not. It will be ideal if they can start it before referring the patient to a psychiatric care, but it not always happens, So I would say in the not so ideal situation, if you have a patient that comes to you and is psychotic and you need to start her on something, at least start her on an antipsychotic and even benzodiazepine to calm them down, and send them to the emergency room, but in terms of so there are two kind of situations and they did studies on this. So there is the situation of a woman with bipolar disorder that is pregnant and might be doing well during pregnancy, but they suggest that you start the lithium during pregnancy to prevent an episode and the postpartum psychosis. There is another subset of patients that just have postpartum psychosis, and for some reason that happens, they don't have a history of bipolar, they just have postpartum psychosis. So in those cases, you can just start the lithium as soon as the baby is born, and it will prevent the postpartum psychosis. But the literature suggests that if somebody in advance has bipolar disorder, even if they are doing well, you start it a little bit earlier before delivery, the lithium. So if you see a patient that has bipolar disorder and you don't feel comfortable managing the lithium, it's good to send them in advance. They are going to deliver at some point. So for that time, it's good to send them to see a psychiatrist. The other thing is for me, it's like when one of my patients with bipolar disorder is about to deliver, I'm in contact with the OB, so I tell them what to do, really, when the baby is going to be born. I tell them when to give the lithium, when to check blood levels and everything, because they don't need to know it. It's not their specialty, so.
Do you find that they're usually pretty receptive to that?
so.
Okay.
And that's just
I
another,
find, what?
that's just another good plug for the Prism line because, you know, as you know, we don't have that many psychiatrists even in the whole state of Montana, let alone in some of the smaller communities, and really getting that word out about the referral line so that they're not doing this work by themselves, because we don't want them to delay treatment by waiting 2 more weeks or even a month
Yeah,
to get in somewhere.
yeah,
The ED providers don't know this information either. So, you know, that's where this referral line is really the best of both worlds.
yeah, that's right. Anyone wants to talk about any case they had, like with patients that were very acute, or even if it's not a patient that was acute, that they were concerned about, or?
I can go. I actually have a patient that I saw just right before our call today. So she is a late 20s, early 30s, and I've been seeing her for a couple of years. We've been doing a lot of EMDR work related to past childhood trauma. And she's pregnant now. She's 20 weeks pregnant, and her pregnancy has triggered a previous back injury as well. And so she's almost ultimately on bed rest. She's a pretty fragile, high acute patient anyways. And in the last month now, she's been suicidal. And suicidality isn't really something that she's had suicidal ideation for quite a while. And over the years, it's kind of fluctuated. But for the first time ever, she's suicidal with a plan. And so it's kind of perfect storm right now between her underlying mental health condition, and now she's pregnant. She has this back injury. She's in a ton of pain. They can't do much about it because of her pregnancy. And she's ultimately on bed rest. She's very isolated. And so we've increased sessions to twice a week. I'm seeing her twice a week. Her husband's been coming in with her. And so that's been the biggest piece that I've really implemented now with this suicidality. He's been in really more frequently, and we're constantly checking in about safety plans, means to a plan. Her plan was to overdose, so he has taken control of all of her medications. I've been in contact with her. She has a psych NP on board who's increased. So she's just actually increased last week up to 200 on Zoloft, and she's been treated on Zoloft for quite a while, and she's been pretty stable on that. But I don't know if there's anything I'm missing, anything else you should be doing, anything else you would recommend, Dr. Frieder?
So she is in a pretty difficult place, because of the pain. Also, pain is a risk factor for suicidality, like it's very uncomfortable to be in pain,
Yeah, and they can't treat her pain. They can't. She was actually medically hospitalized in the first trimester because of this back injury, because of the back pain. And they weren't really sure what was going on, and they really couldn't stabilize her pain levels. And there is very little they can do for her. She's doing physical therapy, and really they're just having her do stretches. There's just so little they can do for her at this point. Ultimately, they want surgery, but they're not going to do that right now. And I'm afraid it's just going to get worse as she continues to get bigger. It's just going to put more pressure on her back and on her pelvis. And I can just imagine this pain and is going to get worse. And I'm worried about that. I'm worried about her ability to cope with increased pain and increased discomfort as the pregnancy progresses.
Is she sleeping?
She sleeps pretty well. Yeah, she's able to sleep. Really, like she needs to be lying flat. And that's what provides her the best relief. So she's sleeping well, but that's all she's doing. She's just in bed all day long. I've been able to get her to come into the office for appointments. We were just doing telehealth, and there were some appointments where she, like her room, like she's just like in a dark space. And I would have her husband come in, like open the blinds. And he would say, we don't live in a cave. Like we need to open the blinds. We need to get some sunlight in here. because she has just been so depressed.
And does she have any protective factor?
Oh, no. I mean, yes, but no. She's pretty isolated from family. Her family is all out in Utah. She and her husband moved here 2 years ago. They have a little bit of a social support, but they don't have huge social network here. They had been practicing in the LDS community, and they've recently left the church, and so she's lost that support. She had some pretty good like coping mechanisms, like, you know, just like some physical activity, and just like she was really crafty, but she can't even do really any of that at this point. She has a job that she loves, that she was able to get on at our local health department, and has really been like the leading kind of CDC reporter throughout the pandemic. And she loves that, but she hasn't been able to go into the office because of this injury. And so there are very few protective factors at this point. I would say the pregnancy is probably the biggest one.
That's what I was going to ask, how she feels about a pregnancy.
Very excited. They tried for quite a while to get pregnant. So she's very excited about the pregnancy. But even that, like the first time she had disclosed the suicidality to me, even at that point, it was like this pregnancy wasn't even enough at that point. Like she just couldn't hold on to that piece, which was my probably biggest concern.
Yeah. So it's very important that the husband is involved, you know, and to keep like the work you do with her, the alliance, you know, and the other thing, you know, is that it was good that they increased the Zoloft, because one thing that can happen, that happens in pregnancy as the pregnancy progresses, the patient might need higher doses of the medication. So it's possible that also the Zoloft wasn't working well enough, you know?
Sure.
And it might be that she needs higher doses.
Well, I was going to ask, what is the highest dose of Zoloft?
So the highest dose is 200, but I've had patients in pregnancy with higher doses because they need a higher doses because of the metabolism. So even if it's 200, I still go higher, you know?
And then is it common that once she delivers the Zoloft, that comes back down pretty quickly, or how do they usually do that?
So you can do it slowly. You don't have to do it quickly, you know, usually over time, like you can go back to her usual dose.
Okay.
Yeah.
Are there any concerns about like too much? So like if too much Zoloft, so once she delivers, you know, that metabolism is no longer what it was. Is there a window that it would ever be too much Zoloft?
So we don't really know about that, what is too much, you know. The thing is that it's based more on side effects, what side effects she has. But yes, I will go down, you know, it depends what dose, you know.
Sure.
I have a patient now that she has OCD and she's pregnant 30 weeks and she's taking 350 of Zoloft, you know. It's a high dose, like I'm not happy with it, but she wasn't doing well, and Zoloft is what works for her, you know, and instead of changing it.
Yeah, and it's interesting because this client, she came to me she told me, and I haven't seen anything, but she came to me with an OCD diagnosis. She said she had been previously diagnosed with OCD. I haven't really seen any of that, and so I'm not sure. Maybe it is just being treated effectively with the Zoloft, but we really haven't had any like breakthrough OCD symptoms since I've known her, and I've been seeing her almost 2 years now.
But do you have a safety plan, what to do in case if it gets worse, like with a husband?
We do have a safety plan in place. And honestly, with my clients, most of the main safety plan is they can call me, especially when I have acute patients. You know, it's not something I like to regularly practice because I have my own life in the evenings and I try to maintain boundaries. But with a client like this, we have a very good alliance. I am very confident she would reach out to me. She's also very open and honest about this with her husband. So her husband has my number. He can reach out to me as well. And then, you know, I went through, you know, the ultimate plan, like if we do not feel like she can keep herself safe, if husband, if you feel like this is too much, it's the emergency room, and we have two emergency rooms here in Billings. They know which one is the psychiatric one. I would want them, and I told them I would want them to contact me if they were to go down there, just so I could coordinate and let the ED know what was going on. But yeah, I'm very confident she would reach out, or her husband would reach out. They're on top of that kind of stuff.
Good.
Yeah.
Do you think that she would be able to like swim?
That's something I've suggested. She hasn't done it yet, but that is something I've suggested. I thought that, would be some good movement, and I can definitely bring that up. I haven't brought that up in probably a couple of weeks. Yeah, because like something like just be able to like even like, and then like if there was a low temperature hot tub or whatever, we don't want too high, but like would be able to swim and get some like movement in her body again. And then I know that they have like masseuses that'll come to your house. Okay. Maybe like that might help her pain and give her something to look forward to, because it just doesn't sound like she doesn't have anything to like think about besides being in pain and how to like relieve that pain through suicide. And so I just think of like ways to at least give her something every day to try to look forward to. Yeah, that's a great point. And that was actually really what we kind of focused on Friday with her husband, because his thought, he had wanted her to stop working at this point. He felt like working was too much for her. And I disagree. I think that's one of the things she's got going for her right now, something she can look forward to. And so we set up some other things. If she's going to spend time with a friend every Wednesday evening. We did some like other really small behavioral activation kind of things. Like she got a new puzzle that she's going to be working on to look forward to. But yes, you're absolutely right. She's and that's even what she had said this morning. She goes, I just cannot find joy in anything. So just trying, and then she gets really overwhelmed if we try to like set too many goals or have her do too many things. So today it was just a puzzle. Between now and when I see her on Friday, she needs to spend 10 minutes on a puzzle a day. But just trying to get her engaged more socially and just with other things has been really hard. I love the swimming idea, though. I'll definitely bring that up.
Yeah,
again.
I like it.
Thank you, everyone. Sounds like I'm not maybe totally off base, but it's just hard.
It is hard.
Yeah.
I think also it has to do how much you feel comfortable with, with the plan.
Yeah, and I am comfortable. Again, like we have a really, I feel like we've got a really good alliance. She's very open and honest. She's very open and honest with her husband. I'm pretty confident in our plan at this point.
Good.
Yeah. Thank you.
Any questions?
So I wanted to say that I've really been enjoying all these sessions. So I've done some clinical work in an OB office. I just finished up my rotation, and there've been like 2 different ladies who've come in for annual wellness exams that through like my questioning and asking through some of like the tips from these sessions have revealed like they've had untreated postpartum depression for like this last gal was like maybe at least 4 years, if not 6, from her first child. And so I've really appreciated sort of being in tune to all of that and really feeling like can't help them until you identify it, and I'm feeling more confident in being able to like identify and help ask the right questions. So thanks.
So you are in an OB setting? You are in an OB clinic?
Yeah, I just finished that rotation. So
okay.
Yeah.
Were they screening for postpartum depression there?
They do. So like the first gal, she said, she even like reported intrusive thoughts and things, and this was 2 years ago. And when I came in, when she came in for her wellness, she kind of just said something, and I kind of looked at her and I said, I think we need to talk about that more for a second. She goes, talk about what? And I said, well, you just said something. And then all of a sudden she started crying and said that she's had these unresolved feelings and depression since like her child was born 2 years ago. And so then we were able to, like, she feels amazing now. We started her on some Wellbutrin and started her in counseling, and she says she feels amazing. So that was just like a really great, it's like, it just sort of shows, I guess, the flaws in the screening is that they're not answering honestly, then the screenings don't work. But then also the flaw in the system that if they don't come back, except maybe once a year for annual wellness, that they can't catch it.
That's true. That's great. No, it's great to have awareness, and be able to listen with a different ear, like really to these things, because people say things and you just need to know how to listen to that. And that's really good.
Yeah, and then my very last case from at rotation, it was just an annual wellness, and we were talking about her contraception, and she's like, well, I don't want anything that's going to make me more irritable. And I said, well, tell me more about feeling irritable and moody. And she said, what do you mean? And I said, well, tell me more about that. Like, do you want to talk about that? And she just burst into tears and that said she's been like very depressed all these years and no one's ever really asked. And it kind of went from like a wellness visit into sort of this like problem visit, but it was an interesting way to sort of end my rotation.
Yeah, that's great. You really helped them.
Thanks. Yeah, I really feel like I'm definitely more in tune to it because of these sessions. So
that's great.
And I also want to call out the comment from Stephanie. I don't know, Stephanie, if you want to just talk a little bit about that.
Sure. As Cassie was going through and talking about how, there's that flaw in our system if you're not screening, if screening doesn't catch them in that initial postpartum period, I think that that story of prolonged perinatal mental health conditions not being identified or recognized or disclosed it's common, which is very unfortunate. And I think one of the ways we can do that is help, just normalizing that, depression is the most common complication in pregnancy, and, receiving treatment, and then also with things like intrusive thoughts, which might not be so much in the common parlance, people are like, intrusive thoughts, I don't know what that means. But they know that maybe it's something wrong, and coming against that pressure for it to be a perfect, wonderful time in their lives. So doing that psychoeducation piece as well, hoping to help them self-identify with some of those, or self-identify some of those issues. So thank you for that work, Cassie. And it's cool to hear that that this helps.
Yeah.
I know we're coming up on 1 minute till this is over, but Healthy Mothers, Healthy Babies has been working on a crisis mapping project. And so when we have our results and our report done, I'll make sure to share it and we can spend some time coming back. But I think one of the big kind of bright flashing gaps in our system is if we have a single mom and she's not in a place socially where somebody can help her with her baby, and she is in crisis, emergency foster care is really her only option. And I would like to venture a guess that if there was a less scary option for her, she might be more likely to disclose her suicidality, and we might be able to save lives. So I just kind of wanted to put it out there as just kind of an awareness that, several of us are kind of coming around to, like, that might be a major contributing factor to this terrible death rate. So
yeah, that's right.
Yeah, thanks, Dr. Frieder. That was a really good one.
So thank you everyone for coming.
Thank you.
Thank you.
Bye.
Bye.
Thanks all. Sure.